Yeah. You don't mix it with the focus or anything. No, I'm joking. I think you said it, sorry.
Fantastic. Well, welcome everyone to a standing room only launch of the Health and Prosperity Commission here at IPPR. My name is Harry Spinner. I am the Interim Executive Director here at IPPR, and it is my absolute pleasure to welcome you to today's event. We are hugely excited that after 3 years of hard work, we have published the commission, which went out yesterday, and was picked up all of the newspapers, all of broadcasts. Fantastic reception to what we think is a really well-timed intervention. We kicked this work off in the wake of the pandemic. And the pandemic had exposed, I think, that we had underinvested in and under-reformed our health service, and that we under-prioritised health across the rest of the government. And as a result of that, we saw worse health outcomes, but also our public finances were hit and people's pockets were hit worse than they needed to be. And we recognised that it was not just one moment in time, but in fact, a structural problem with the way that we make policy and the way we do things in this country that needed resolving, both to give us more fulfilling, longer, healthier lives, but also to give us a more prosperous society. And the Commission set out to make that link and to set out what policymakers could do to ensure that we tap into what we think is a vital, untapped potential of health in our society. So to summarise the key argument, and the argument we hear time and time again today, is that a healthier country is a more prosperous one, and that we have to invest in health, not just in the department, but also across government and across society to unlock that potential. And we've been really delighted as well by the pickup from policymakers. So we had a Dem conference earlier this week, and then David spoke about it in his speech. One of the first things that we're speaking is we're delighted to join us here today did when he became Secretary of State for Health and Social Care, was to say that the department was now an economic ministry. And that's really a testament, I think, to some of the arguments that we've been making, and we're delighted that Wes is going to talk a bit more about that, what that means here today. Before I hand over to the start of the show to Wes and to Aaron, who has co-chaired this amazing commission, I am going to say a few thank yous, and I apologise to everyone who has to sit through this. But after 3 years of work, we do need to recognise all of the work from the huge team of people that has gone into this. So firstly, I would like to thank the team, in particular Chris Thomas, who's led this work. Without him, this would not be happening. It's been an absolute gargantuan effort over 3 years. I would like to thank Ethia, Carsten, Path, Annie, Henry, Rachel, and Jamie, all of whom have contributed to the research that is in this final paper, but also all the papers that are led up to it, so thank you to them. I would like to thank David, Liam, Georgia, Emma, Richard, and Abby. They have done all the unsung work to convene these kind of events, to make sure we get media coverage, to make sure that the commission runs smoothly. And of course, Ara and Sally, who co-chaired this work, who have been amazing champions of IPPR, but more importantly, of the causes that we are championing. And to all of the commissioners, and especially to NHS Confed and RCP, who have helped with the analytics and the policy work. At the end, I would also talk about our funders and as well as supporters. But now, what I want to do is hand over to Laura Aradazi, who fresh from publishing a huge report last week, is now publishing another one. So over to Laura.
Thursday, distinguished guests, ladies and gentlemen. Let me start first by saying thank you, Harry. It's been a great privilege to chair the IPPR Commission on Health and Prosperity over the last 3 years, alongside my great friend and colleague, Dame Sally Davis. I've learned a huge amount, and I think I also will believe we drove to very long 3 years. It started very often to remember the first meeting we had, and there was a little alcohol in Whitehall. As many of you will know, last week I published my independent investigation into the NHS and handed the report to the Secretary of State. The data showed a healthcare system under immense strain, struggling to meet the needs of the population across every part of the health service. Access to care as deteriorated. Meanwhile, quality of care, one of the things closest to my heart, has not improved as fast as it should have, and in some cases it has gone backwards. Decades of progress in areas like cardiovascular care risk going into reverse, and we continue to lag behind comparable nations when it comes to cancer outcomes. So the NHS, as the Secretary of State described, is in a critical position. It's important to say because the first step to solving a problem is to be open and honest about it. And that honesty must extend to the health of the nation. As I said in the report, although I have worked in the NHS for more than 30 years, I was shocked by what I have found during my investigation, not just in health service, but in the state of the nation's health. And that's why the work of the IPPR Commission on Health and Prosperity is so important. And so, not just to diagnose the challenges, but to offer some answers. We want a Britain that is healthier and also wealthier. Our work began nearly 3 years ago. The commissioners have worked closely within the team from IPPR to examine the relationship between health education, policy development, expert interviews, and deep and wide engagements with business, large and small. All of these have happened during our work. The output from the IPPR is actually remarkable. I urge you to read it. For far too long, governments and business have seen healthcare as a cost to be minimized rather than an investment that has a return. The idea that health and prosperity go hand in hand is now mainstream. That was one of the more obvious lessons of the pandemic. But the idea is gaining ground in other ways too. I was particularly pleased that one of the new government's first actions was to give the Department of Health and Social Care a new focus on economic growth. And that is thanks to the Secretary of State, Westwood. That's because the evidence is clear. The absolute amount of our lives spent in poor health is rising. Chronic disease is more prevalent. There is a crisis in the mental health of children and young people. And in some communities, nearly a third of children are obese by year 6. We go on and on and on. But this health crisis is an economic crisis too. As IPPR's analysis shown, poor health impacts the workforce, their earnings decline, and productivity suffers. We can recognize that pattern at an individual level very easily. And when we look at the national impact, the picture is stark. Lower productivity, a smaller and a weaker labour market, a hit to GDP. Poor health is a drag on prosperity for families, communities, and also our country. This is the new consensus. It is an argument being made not just by this Commission, but by the most important economic authorities. From the IMF to central banks, there is an increasing global recognition of the need to act, and to act boldly. In the 19th century, we tackled infectious disease with slum clearances, sanitation reforms, and workforce protection. In the 20th century, we introduced health insurance in 1911 and universal healthcare in 1948. Today, we must summon a similar level of ambition with solutions that are fit for the 21st century. That's why the Commission's final report proposes the creation of a health creation system to operate alongside our sickness-oriented NHS. As people spend more of their lives in poor health, we need to be more proactive. We can't wait until people arrive to the A&E in crisis. We need to create good health where people live, work, and grow. The health creation system cannot be a traditional public service like the NHS. It needs to be something very different. A new partnership between government and employers, innovators, entrepreneurs, communities, and wider public services to inject good health into all aspects of life. If we get it right, the rewards could be enormous. Better, healthier, longer lives, a more successful economy, and an NHS that is sustainable for the future. It's time to bring health creation into homes, workplaces, and communities. And I'm pleased that the government is taking forward some of these items, with workplace health checks, tobacco control strategies, and efforts to anchor the NHS more deeply into local communities. These moves could mark the beginning of a journey: better health, a stronger NHS, and more prosperous Britain. As we launched this commission, we set out to test one hypothesis: that better health was our country's greatest untapped resource. Today, I believe we proved it. Our proposal offers a vision for better lives, thriving businesses, and stronger communities. Health is an investment, not just a cost. And the prize is not just more prosperity, but better, longer, happier, and healthier lives for all. It's been a remarkable journey over the last 3 years. And let me end by saying an enormous thank you to all of you who've been involved in this report. Thank you to my co-chair, vice chairs, and fellow commissioners. Thank you, Harry, Chris, and the whole IPPR team. And thank you to all of you for coming here.
So it's now a pleasure to welcome Wes Sweeting, Secretary of State for Health and Social Care to stage to say some comments. Wes.
What's my slide? I'll try to help you. I don't think I have a slide. You're in my very bad start. I definitely don't want the lifeline. There we go. Thank you very much for inviting me here today. Phone's on silent. A lot changes from opposition to government. I went from an office of 7 staff to a department of 3,500. People insist on calling me by my title rather than my name. And the most frustrating change, and I'm sure I won't be the first to have said it, has been the pace or lack of it at which the whiteboard machine works. So for Ara to have published 2 reports in the past 2 weeks, both over 100 pages long, with expert analysis and huge amounts of data, is really putting the British state to shame, especially on the first of those 2 reports he put together in just 2 months. He is on a one-man mission to solve our country's productivity. But the Darcy investigation into the NHS and the final report of IPPR's Health and Prosperity Commission complement each other. Taken together, alongside the OBR's Fiscal Risks and Sustainability Report, they depict a perfect storm of rising pressures on the NHS, growing numbers dropping out of the workforce, and spiralling costs to the public purse at a time when there is already a £22 billion black hole in the public finances. This is what we are up against. I've been in the Department of Health and Social Care for 2 months. Day after day, I've shown graph after graph with all the lines going in the wrong direction. Recognising this is criticised by some for being gloomy. It's not actually, it's something this country hasn't been used to for a long time. This is honesty. This country has had enough of politicians who turn a blind eye, brush issues under the carpet, and delay decisions until after the ever-looming next election. This government has resolved to be honest about the problems facing our country and serious about solving them. You saw both in Keir's speech last week, honesty about the state of our NHS and the serious agenda for turning it around. As the Prime Minister set out in his speech, continuing with the status quo isn't an option. Sticking masters won't cut it. We're going to have to make big changes, many of which will come up against loud opposition. So don't be surprised if I'm making a case for change at the same time. Anyone was in any doubt about the scale of the challenges before the NHS, and the Darcy investigation published last week made it abundantly clear. I asked Ara for hard truths, Waterloo, he's delivered, bedside. He has given a raw and honest diagnosis. The promise that the NHS will be there for us when we need it has been broken for almost a decade. 100,000 infants aged between 0 and 2 were left waiting more than 6 hours to be seen in A&E last year. Cancer is more likely to be a death sentence for NHS patients than patients in other countries. 50 years of progress on cardiovascular disease is going into reverse, and patients have never been more dissatisfied with the service they receive. The report is equally damning on the causes. First, a decade of underinvestment, which led the NHS 15 years behind the private sector in technology, with fewer diagnostic scanners per patient than almost every country, including Belgium, Italy, and Greece, and mental health patients treated in Victorian cells infested with vermin, where 17 men are forced to share 2 showers in 2024. Second, the disastrous 2012 top-down reorganisation led by Andrew Lansley. The report states, it took a scorched earth approach to health. Just imagine if all the time, effort, and billions of pounds wasted on dissolving and reconstituting management structures had instead been invested in services for patients. Clearly, the NHS would not be in the mess it finds itself in today. Third, coronavirus. The damage caused by the pandemic has been plain to see. But what we didn't know until the Darcy report is that the pandemic hit the NHS harder than any other comparable healthcare system in the world. Patients in this country saw far more operations and routine care cancelled than anywhere else. It's not just the Conservatives didn't fix the roof while the sun was shining. They doused the house in petrol, left the gas on, and COVID just did the match. That is why the backlog ballooned to 7.6 million today. When I used that metaphor in the House of Commons last week, a Conservative MP from the Tone Police Department told my tone was inappropriate and not fitting the chamber. It felt very much like an arsonist pecking the fire brigade. Fourth, the failure to reform. 17% increase in staff working in hospitals, which didn't lead to better outcomes for patients, but a huge fall in productivity. Staff put into the wrong place without the tools to do it. Instead of treating patients, too many are trying to find the beds, find somewhere to discharge patients, or dealing with slow, creeping, outdated IT. An enormous waste of talent and money when so many other parts of the NHS were crying out for investment. And the effective reforms implemented by the last Labour government, which were better performance and better care for patients, were mostly undone. Activity-based funding was ditched in favour of block contracts, incentives to reform and modernise ways of working have been stripped out, translated into plain English. Too many parts of the NHS are now paid for efforts, not for outcomes. That has to change, and we'll be saying more about that in the coming months. Some of the most shocking findings in the Darcy investigation weren't about the sickness in our National Health Service, but the sickness in our nation. Children are sicker today than the generation a decade ago. Adults are living longer, but falling into ill health earlier in life. And as this report from the IPPR puts it, we are in danger of literally becoming the sick man in Europe. The result is a rising tide of pressures on the NHS. I've said it before, but I don't think the message has yet got through. If we don't act now, ever increasing demands for healthcare threaten to overwhelm and bankrupt the NHS. Our sick society is also holding back our economy. A drop in productivity due to ill health has cost our economy £25 billion since 2018. 900,000 more people are off work than would have been on peak pre-pandemic trends. That's more people than Tesco, Sainsbury's and Asda employed put together. Fail to act. By the end of this Parliament, 4.3 million people could be off work sick. Millions of people left behind, ballooning and growth plan. We need reform of the health service and public health reform too. That was the great thing about the Darcy report and actually about IPPR's conclusions today. This is not a left wing or a right wing view of the NHS. It told hard truths to both sides of the debate, and it forces me now to take on both left wing and right wing orthodoxies. Voices on my shoulder. The simplicity say, we'll call them. We're encouraged by what you say in my NHS report. You're the only party that can do it. Now get on and deliver. But we can't stand this nanostate stuff. We need to stop. The Guardian says, you're absolutely right on prevention, and we love nothing more than filling our comment pages with pieces about social determinants of health. But we're nervous about all of this crass talk of NHS reform. It sounds far too much like Alan Milburn. And we've heard this back, which is terrifying because he makes that shooting look left wing. Both are half right and half wrong. The lesson from the Darcy report is clear. The Tories did neither. This government has got to do both. Unless we do public health reform, the right will have to accept higher costs for healthcare, paid for by higher taxes. I don't think that's the price working people can afford to pay. The left have to accept health service reform, or there will be no health service, at least not as we currently recognise it. Reform has always had opponents, often vocal and powerful opponents. But believe me when I say, the Prime Minister and I will face down that opposition. because it is in the interest of patients, the health service, and taxpayers in this country. It really is reform or die, and we choose reform. As the Prime Minister said last week, radical surgery is required. We will publish a 10-year plan early next year that will set out how we will deliver 3 big shifts in the focus of the NHS, from analog to digital, hospital to community, and sickness to prevention. And what gives me confidence that this can be done is the innovation we've already seen taking place in our health service and our country today, pointing the way to a better future. At the Royal Free Hospital in London, the hospital which treated my kidney cancer, new PET scanners work 4 times faster than standard. Patients are seen days from weeks after being referred. Diagnosis that can be the difference between life and death. Think of the number of lives that could change if rolled out across the country. That is why we are committed to putting AI-enabled scanning in every hospital, freeing up valuable staff hours and getting patients diagnosed much faster. In the southeast of England, virtual wards have led to 9,000 fewer hospital admissions per year. Patients living with long-term conditions like heart failure are cared for from the comfort of their own home, freeing up vital hospital beds and saving more than £10 million. Our commitment to invest in more district nurses will make sure more patients across the country get the treatment they need without having to step out the front door. Better for patients and less expensive for the taxpayer. And as the Prime Minister said last week, by marrying our country's leading scientific minds with the care and compassion of the NHS, the fruits of the revolution taking place in life sciences can be secured for NHS patients. That public-private partnership will be fundamental to the reform agenda. Take MS patients. Right now, many are treated for a 4-hour blood infusion, a long and difficult ordeal. Soon, thousands will be offered an injection that takes 10 minutes. Just imagine the difference this will make. The hours returned to patients to live their lives, and the thousands of hours of clinicians' time freed up for the millions of other patients stuck on waiting lists. And when it comes to prevention, the healthy society we need to build won't just come from the action we're taking as a government to ban junk food ads, pass the tobacco and vapes bill, or introduce health checks in workplaces and on high streets, nor will it only come from the reforms we will make to the NHS so that it can reach patients sooner, diagnose earlier, and treat them faster. In May, we saw the first NHS patients treated with a personalised cancer vaccine at University Hospitals Birmingham. These vaccines could prevent cancers from returning after surgery, sparing thousands of patients and their families the torture of recurrence. That's why I'm determined to rid my department and the NHS of any cultural snickiness about dealing with the private sector. Make the NHS the best partner in the world for the life sciences sector, and make sure that NHS patients reap the rewards. That is what Keir Starmer's mission-driven government is all about. It's about mobilising the public sector with business, the voluntary sector, and civil society to achieve big, lasting change for our country. And in doing so, we won't just be building a healthy society, but playing our part in contributing to the government's #1 mission of economic growth. So in conclusion, we've hit the ground running in the past 2 months, bringing an end to the junior doctor strike, which has lasted 18 months, cost patients £1.5 million for operations appointments, and cost taxpayers a staggering £1.7 million. And we've begun to fix the front door to the NHS, with an additional 1,000 GPs hired by the end of the year, beginning to reverse the decline in primary care over the last 14 years. It's 76 days since the general election and 76 years since the founding of the NHS. There are no quick fixes for an institution of this size and age, especially when damage done by the Conservatives is 14 years in the making. None of this will be easy, and it will take time. And there will be more arguments to be won along the way against the ideologues who don't believe the NHS should have any private sector, and the modern-day Luddites who resist growth use of technology in the health service. This government will never be afraid to take on those arguments and take the difficult decisions needed to deliver the change that British people voted for. If we see this through, the prize is huge. A healthy nation where fewer lives are lost to the biggest killers and fewer people are forced out of work through preventable disease. A healthy, growing, prosperous economy with the proceeds of that wealth shared across our country. An NHS there for us when we need it once again. Recovered, reformed, sustainable for the long term. That's what we'll do about it. Thank you very much.
Really powerful speech and huge progress already. So congratulations. I'm now going to open up questions. We're going to do this in two parts. So we're going to take questions from journalists first, and then questions from everyone else afterwards. So if you're a journalist, please keep your hand up, and if you're not, can you restrain yourself? So, thank you.
All of the front two row embrace the entitlement of our meeting.
Can I take Ali Force to Sally?
Thank you, Section 8. So I'm going to go on today, which we know that maternity services and continue various, as she said, ones and various at risk. She's told us that she wants an urgent meeting with you. Would you be happy to do that? And if so, when? Well, I've also asked on the row of donor gifts that are reported today. You accepting this whole row has been overplayed, would you understand the strategy? Thanks.
Two things. The first one, yes, I have huge respect for Donna Ockenden, and when it comes to the crisis in our maternity services across the country, it is one of the biggest issues that keeps me awake and worrying about the quality of care being delivered today and the risk of disaster greeting women in labour tomorrow. I think that what we've seen in the case of specific trusts are problems and risk factors that exist right across maternity services across the country. And we're keen to make sure that when it comes to the work that Donna Ockenden has already done, we make sure that those lessons are applied, not just in the case of those specific trusts, but actually right across the country. And we're determined to get this right. Look, secondly, I'm now outed as a Swiftie. But I think the important thing is transparency and accountability, and there are no conflicts of interest. And that's why we have the transparency that we have. That is a good thing, and will continue.
Can I take Kate Dublin in Helen?
Thanks. Kate Dublin from The Independent. It's been announced that Choice Parker Hospital in Coventry is to shut following an expose by The Independent of allegations of shopping practices there. Can I ask for your comment on that, and how important do you think it is to shine a light on these kind of problems?
Well, firstly, sunlight is the best disinfectant. And the reason why on day one I came in and said the NHS was broken was because that candor, that statement system today, the Secretary of State, gives permission and provides leadership to everyone working across our health and care system to be honest about the things that they are seeing, experiencing, and often terrified about in their daily working lives. When you have a political culture that seeks to prioritise protecting political reputations over protecting patients, you breed a culture where patients are more at risk. If you are not prepared to confront hard truths about the state of maternity services, long waits in A&E, the struggle people face getting a GP appointment, the lottery of an early cancer diagnosis versus later cancer diagnosis, and the impact that has on your life chances and life expectancy, you end up with a situation we're in today, which is a system that, despite amazing professionals who care very much about their patients, we see an appalling state of failure, which is letting the patients down. And so creating that culture of honesty about challenges means that we will be able to meet those challenges. You know, as we said around Darcy investigation, if you get the right diagnosis, you're more likely to write the correct prescription. So that transparency is really important. That honesty is really important. That you will not find me ducking hard truths over the course of this talk, especially because we're not going to fix these things overnight. On that case specifically, this is truly shocking. The way in which children were treated in a place where they were supposed to be safe. I think the closure decision is the right one. We're working to make sure that the placements, appropriate placements are provided for those young people. And I think it is actually a truly terrifying example of what happens when patient safety is not taken seriously. And I don't want to read about any more of these sorts of cases, and we've got to make sure that everything we are doing throughout our health and care services, the safety of the patient, the safety of the care user is the first consideration.
Can I take a question?
You wouldn't ban bringing cake into offices, you remember? Is that still the case now in government? And has NATO gone too far by banning certain in public gardens? Just finally, it's very nice to go for yourself.
It is. Thank you very much. Always the tech compliments right together, especially from Chris. A couple of things. I have not banned cake in the Department of Health. In fact, I was at NHS England the other day and saw an abundance of sugary treats in our building. I'm not reported them to the chief medical officer yet, but there's a serious point. There's a serious point here. I'm really not interested in being a fun police or telling people how to live their lives, and people certainly won't have to worry about closing their curtains at night in case I'm peering through the window, looking what they're eating, drinking, or smoking. That's not the kind of society I want to live in. But we do have to take this issue of chronic disease seriously, and the impact it's having on our lives, our life expectancy, our ability to live our lives to the fullest extent for the longest time possible. I think if we are in this appalling situation at the moment where we are living longer but becoming sick sooner, that's terrible for quality of life. It's also terrible for the economy, for the labour market, and for the financial sustainability of our health and care services. So when it comes to having some coke or going down the pub, I think everything in moderation. And crucially, when it comes to measures we are considering, especially where this involves legislation, I don't believe in doing things to people, I believe in doing things with people. We want a genuine national conversation about our health and our well-being and the types of reforms that we might want to see. Smoking is at the easier end of the spectrum, frankly. It is still the biggest killer. It is uniquely harmful, it is uniquely addictive, and there are unquestionably harms that occur through second-hand smoking and passive smoking. We've got to take that seriously. But we're going to consult, we're going to engage, and we're going to enjoy the national debate in the process.
I'm going to take two more journalist questions, and journalist. And lady in the top, yeah.
Thank you, one of the key recommendations from the IPPR was moving to enablement structure, which essentially means doing away with the partnership model. But last week, Lord Darcy said that GP partners have the best financial discipline in the NHS. Where do you stand on that? What are your plans for the independent contract model?
I don't think building a neighbourhood health service means moving away from the GP partnership model. I started deliberately a debate on this by making everyone really angry with an interview in the Times in January the other year, deliberately to provoke a debate about the future of the partnership model. Because what I observed was a partnership model that's in decline, where very soon we're going to have more salaried GPs and partner GPs, and where GP partners themselves are describing anxieties about the future of their profession generally and about the future of the model specifically. And we said we were genuinely interested in debate and want to work with the profession to rebuild the general practice. And actually, I think as Aaron's investigation shows, that there are actually some enormous strengths that come with the partnership model in terms of the efficiency, the innovation, the continuity of care that the doctors are really committed to providing. So the model, the partnership model itself is not my first consideration. My first consideration is how do we make sure the general practice is attractive to people thinking about careers in medicine, and how can we do more in primary and community, and get some of those services shifted out of hospitals closer to where people live. So I think it's kind of a good example of how when we say we're going to consult and we're going to engage, we're going to listen, we genuinely mean it. I know when most people hear politicians say we're going to consult, they think we need to impose our view with a veneer of public engagement, and that's not how we proceed. Where we're clear about what we want to do, we'll say so. Where we're engaging in consulting, we're genuinely interested in finding answers to our questions. The final thing I'd say in relation to general practice, I think GPs are really up for reform. I think they're desperately anxious about the state of general practice. They want to see the left shift, and they want to see this government really deliver on our ambitions for general practice and primary care. And that is why the confrontational approach of the BMHGP committee is unfathomable. I can totally understand how I ended up in conflict with the last government. I'm still struggling to understand what I want to find this one.
She's too loud to check.
I've always been told to do that shit, but I'm very in the centre.
Sophie, since the day you are.
Hi, thank you. So IPPR in the report recommends free school meals for all primary school children. Doctors, dentists, teachers all wrote you last week calling for the same thing. Is this something you consider introducing? Secondly, if I can, how do you feel about people having to sell their homes to pay for social care, and when are you going to introduce an cap on costs?
So two things, and they're both related. There are lots of things that we would like to do, but we are constrained by the state of the public finances, and this is precisely why we have to keep economic growth as the number one mission of this government, and why all of us have a responsibility to drive towards that growth, because when the economy is growing, you can invest in public services and put more money back into these pockets without having to increase the burden of taxation. We have a fiendish political challenge in the public finances, far more difficult than we anticipated. Yes, we knew the economic outlook was poor, and that the previous government had been both irresponsible in public finances and irresponsible in terms of their stewardship of the economy. What we didn't expect to find was the extent to which they were spending money that the government simply did not have, spending the National Reserve 3 times over, an unprecedented amount of in-year profligacy, and a level of spending that we've never seen outside of the unique circumstances of the pandemic. That is why we are having to make hard choices, and they are not just the Chancellor's hard choices. This is a shared endeavour, and we recognise that when we talk about hard choices, those are hard choices for the country too. And as the Prime Minister will set out next week at the Labour Party conference, by taking the hard decisions now, we are fixing the foundations to build the right future that we want to see for our country. So there are lots of things people are going to want to see us do. We're going to have to get used to saying as the resources allow. And finally, and this is a good case point, the dual on charging reforms. I think it's outrageous actually that the last government promised to introduce charging reforms in October next year, when they must have known full well the advice that I received on day one in the department, which is firstly, if the money was there, the preparation hadn't been done to actually roll out the charging reform. So operationally, the system wasn't ready. And secondly, the money wasn't there. So they went into that election and lied to millions of people across the country, creating false hope and false security. And that's not the way this government is going to behave.
Fantastic. I'm now going to take around from the audience. I'm going to take a couple. Ben, to you, and this microphone can go.
So I'll ask one last point.
Hi, it's Ben Richardson, managing partner at Carmel Park, so a specialist in healthcare consulting and data. We observed Darcy's report calling attention to the amount of money spent on the acute rising from 49% of the NHS budget to 58%, so the precise inverse of the state policy about shift. And I wondered if you're prepared to make any specific commitments about either the quantum of money or the processes and capabilities in the NHS, because when we talk to our clients across the NHS, they reflect that they no longer commission services, they just roll money over And if you start the practice of looking at the return on investment, so just want your thoughts on this.
Yeah, yeah. And the lady just here in the green top. Yes, that's right.
Thank you, Lucy, for raising mental illness. Thank you for brilliant reports and great speeches on Tuesday. And hugely recognise the and welcome the recognition that mental health is getting at the moment. But with we're seeing increased suicide rates, we're seeing really twice as long waits for mental health treatment for people who are sensitive to elective surgery. And just wondered if you could talk a bit more about reform and if that includes fair funding, recognising the previous report that IPPR have done where fair funding for mental health services is often significantly prioritised.
And that's one more. Something's here and there. Just check this out again.
It's very hard from health policy inside. Secretary of State, last week's data review highlighted the £13 million NHS backlog and maintenance funding needed. Today's IPPR report highlights the future generation health plan. Both of these would require spending. In the government's fiscal plans, do you have any thoughts in progress about where you might visit us to be able to fund those things?
Firstly, on specific fiscal announcements, I'm definitely not going to get ahead of the Chancellor and the budget and spending review because I know what's good for me. What I will say is two things. Firstly, I'm committed, the government's committed to grow the proportion of the NHS budget that goes into primary care. That change takes time and it needs to be underpinned by a credible reform agenda. But that's the commitment we want to see. Money tells you about priorities, so we'll make sure that we follow money in the right direction to really underpin in a meaningful sense the shifts that we're describing. And then in some ways that also links to Andy's question. I'm determined to break the doom loop that we are stuck in, where day-to-day pressures in the NHS and a lack of control on those pressures and those budgets leads to the raiding of capital and tech budgets to plug day-to-day shortfalls. It's short-termist, it's harmful, and ironically, raiding tech and capital budgets to plug day-to-day pressures just makes it hard to contain those day-to-day pressures into the future. So it is a doom loop, which is really undermining productivity in the system. That is why my approach to forthcoming spending review is to look at where we can put our investment on the capital and tech side to improve productivity in the system. I have to be honest with everyone, it is not going to be possible with a single budget or a single spending review to correct 14 years of underinvestment. It does take time, and that's why I think prioritising those investments that will unlock productivity gains and save money and improve the experience of patients has got to be the priority right now. And then on mental health, we're committed to mental health act, that was in the first speech, and we're forward to seeing the introduction of that bill in Parliament in the not too distant future. Many of the commitments we made in our manifesto were really at the prevention end of mental health challenge. So, having mental health support in every primary and secondary school in the country, having more community mental health clubs, it gives us a greater chance to get in there early before we see the acuity of mental illness escalate to the really appalling outcomes that too many, particularly children and young people, suffer. We also committed to create 8,500 more staff from the government to go on waiting lists, and I want to shine a sharp spotlight on what all some of those more hidden waiting lists beneath the overall elected number that we tend to focus on. We've got to keep an eye on the mental health list, we've got to focus on the paediatric waiting list, generally, by the way, shocking the extent to which we overlook children's health needs and health outcomes in this country. And so we will do that. The final thing that we need to take seriously is at the moment, especially when I think about those waiting lists for services which are stretched today, we've got to keep focus on not just the mental health of children and young people, but the well-being of children and young people. and we've in particular got to manage the risk of only pathologizing those children and young people who have all sorts of stresses, strains, pressures that impact on their well-being, and just pat them off into a waiting list of CAMs alongside children who've got really quite urgent need. And that's part of the prevention agenda, that we've got to take that seriously and make sure that we equip particularly children and young people, that this applies to adults, I think particularly in terms of mental health, equip people with the tools, the resilience and the ability to kind of talk openly about stresses, strains and pressures. So we get there early, nip in the bud, and don't have to turn into serious mental illness, which is a real issue, particularly for children and young people. But when you look at young men's suicide rates, this is an issue for us.
Thank you, Wes. I'm going to draw to a close there, and I'm sure there's lots more questions that people want to ask Wes, but we don't want to detain you too long. Thank you for your time, to make the time to come and launch this with us here today. We hope you find it useful and useful to look out how to solve the many challenges facing the House.
Well, I appreciate that. Thank you to you and the whole IPPR team for the full leadership you've shown in the space in being really helpful to us in terms of framing our priorities, our outlook and our policies. So long may that work continue, and thank you to all of you for not just engaging today, but no doubt rocking up in numbers to later conference next week, and many other opportunities there will be to contribute to the discussion, to challenge and test the government on our priorities, and hopefully to be part of the team that we will need to build to take the NHS from what is objectively the worst crisis in its history, getting back on its feet, making it fit for the future alongside great social care that we're all proud of. So thank you very much. Thank you very much.
I'm now going to invite Thomas, who's headed up the commission for the last 3 years, up on stage to tell you a bit more about the detail of the proposals and that evidence that we've had. So, Chris, over to you.
I do have slides. Sorry, I'm going to go. Okay. It's obviously so many of you, it's not an unusual slot to follow the Secretary of State, but I'm going to talk a little bit about the detail and the evidence that we've created. But I want to start by talking a little bit about where we were at the launch of the Commission first. It felt a very different country at that point. We just experienced 2 years of COVID-19, of the lockdown restrictions that we all experienced. And I suppose the conception of the Commission for Health and Prosperity began by thinking that some of the challenges that COVID briefly weren't just isolated to the shock pandemic event. Indeed, in 2020, what we've seen was the biggest one-year fall in GDP since the Great Frost swept Europe's agrarian society. And that, to me, and to us, was testament that our economy sits on a bedrock of good health, good population health. And that was the inspiration. Can we understand that essential link outside of and informed by COVID-19? And in doing so, can we build a bigger coalition, a more compelling case, and a case that gets through the economic test as well as the social justice one, to take forward a different approach to health? Since that kind of inception of that idea, the Commission and the research team that sits behind it has written 200,000 words in 10 different reports, including the final report that we released yesterday. That's about the length of one of the Lord of the Rings books. There are less wizards in our reports, but there are more policy ideas than that. And so what I'll take you through is then just some of the things that we've learned and put forward about this link between health and the economy. I'll talk a little bit about some of the policy that sits behind our plan for the country in the future. So the reassuring thing for us is having set out with that key hypothesis that Lord Darcy spoke about earlier, that a healthier society is a more prosperous one, that health is our greatest untapped resource and asset to a stronger economy and to a better society, is that indeed the evidence does support that case. Health in a huge number of ways is really important for our individual prosperity and strength of our national economy. What we didn't want to do is just explore that from the perspective of if we have better health, we have X £100 billion more GDP. We wanted to explore specifically how does health relate to some of the biggest structural challenges that the UK economy faces today. And we talk about a few in our final report. I think one that's worth starting with, because it's been such a focal point for economic institutions, the Treasury, the OBR, the International Monetary Fund, is this relationship between our health and our work. And indeed, we do find that since 2020, compared to what we have expected, given what's happening with demographics, 900,000 more people are missing from the labour market. If trends continue, if what we call the participation puzzle continues, that number will rise sharply to 4.3 million. One of the implications of that is a second challenge we talked about, the link to earnings. The UK has, many people know, has had depressed earnings since the financial crash, depressed railway and wage growth. Well, the link between health and work means that when someone experiences what is often an avoidable sickness, their earnings are likely to fall. In fact, we find on average by around £2,200 for mental health problem for about that amount, slightly less for physical health. What that means is that as much as we might assume that falling sick is free, because we have a universal healthcare system, in fact it's not. There remains a tremendous cost to individual people in terms of their earnings and the cost of living from falling sick. From that, we talk about some of the national economic trends, the things that are impacted by the culmination of those individual experiences, so growth and productivity. And we find that in an economy as dependent on the size of its labour market as the UK has become since 2008, that health and poor health suppresses GDP as a drag on growth. We also show that health and poor health undermine productivity. And that's different depending on what you look at. One of the biggest challenges that the UK economy faces is regional disparities, that we have such economic inequality. But there's an intersection between that and health inequality. There are places in the country where health is excellent, West Oxfordshire, brilliant health, lots of people in one have great prosperity. But in some parts of the country, Nottingham, Blackpool, some parts of Greater Manchester, there are big hotspots of poor health, low prosperity. And so this is a challenge that's more acute for some in our country, and it's more acute for those who have challenges. It's almost always more acute. So what do we have? Well, a picture then where health is really important to the future of our economy, where our health currently isn't as good as it should be, where we're lagging behind other countries on our health outcomes. And so a burning question that we put forward and we think that surely is the one that we all need to answer. Why is our health languishing? Why are we not achieving a healthier country and the prosperity gains that come from that? Our prescription in yesterday's report is simple. It comes down to a single word for me, which is reactivity. We have inherited a reactive approach to health in the 20th century. Well, it might be pretty good when most of our health was acute, when in 1948 the big challenge was we get hospitals and ambulance care that need it. But it is less good in an era of chronic need, long-term conditions, multiple conditions, future effects. What we argue is that we need to confront the challenges that we face today, the specific challenges, and that means building a more proactive approach to healthcare, what we call the health creation system. And I'll talk about the policies that we locate behind that in a second, but it's worth saying that one of the proudest legacies of Britain on health policy is that we have very often risen innovatively to challenges that we face, to moments of health crisis that we've had decisive answers. As a newly urbanised Victorian England post-industrial revolution, infectious diseases pose significant challenges. We were a leader in implementing sanitation, staff clearance, workplace factories, work infections in children 50 years ago. In 1911, we implemented the National Insurance Act. In 1948, we founded the NHS. We have a legacy of bold actions. That should give us hope that we can do that again. But of course, the answer to it will come from looking forward, not from looking backwards. And so the nuances in another moment of health crisis to come from looking to the challenging measure basis there. So what do we need to do? Well, a health creation system would be all about bringing health into the place of the actual outside. We might spend a few weeks or if we're unlucky a few months in hospitals over the course of our life, but we'll spend 80,000 hours a month, 10,000 hours in school, and a huge proportion of the rest of our time in our homes, in our communities, in shops, in high streets, in our communities. That's where proactivity is. That's where we can supercharge the prevention agenda. So let me talk a little bit about what we would put at the heart of an initial approach to a health crisis system, one that takes prevention and works with the NHS to supercharge their agenda. Our first domain is the world of work. Work has a huge barrier for health that can be positive, or that can be negative in some cases. The impact of work on health is rising, particularly on mental health. We show a large rise in mental health resulting causes of work over the last 10 years. We talk about the need, therefore, for healthy work standards. What are our standards for what healthy work looks like? And levers that we can use then to implement, whether that's in some cases incentive. So West Midlands under Northern Labs guidance trial a wellbeing agreement and incentive for small employers to raise work standards. And in other cases, it might be through other means. We talk about a right to disconnect and other standards that we can set in a more regular way. Second, we talk about the need for a healthy industrial strategy. The economy we live in is so important to our health. Simply put, if we live in an economy that is dominated by things that aren't us, well, then we're going to experience harm. So we need to take a look at what we suggest out of the climate paper, which is thought very carefully about the composition of the economy and the future of the economy, deliver a play-on-play approach. On the play side, that's to say that where there are businesses that are innovating, that are bringing forward new technologies and new ideas, that are changing the composition of their workplace as well, we should support that, we should incentivize that. What is a mission-based approach to health, or if not to crowd in exactly those types of people in instant solutions? But where there are products that aren't us that create societal costs, well, then we should change incentives. And that's where we talk as much as the coverage essay focus on the case for things like levies for newspaper principles and portion regulation. Third, we talk about families and start of life. It is really well accepted that education is an investment in the foundation of child's well-being immediately, but also their prospects long term and health of the economy over time. Same is true for child health in 21st century Britain. And so we need to make sure, in the context of really alarming figures on the state of childhood health in this country today, we have the infrastructure, the preventative means to make sure child health is as good as it can be. Our first recommendation is restoration of short start preschool meals. Finally, we talk about place, given those hotspots, those clusterings of low prosperity and poor health that we talk about. There needs to be some targeted intervention to address those clustering challenges. And so we report a recommendation of health and prosperity improvement zones or happy zones, a targeted approach to rebuild infrastructure to bring pilots, bring investment into the health places that are struggling most. We will get the quickest health gains and therefore the quickest prosperity gains by starting with those that have the most gain. And so that's the long behind our recommendation there. Lastly, we talk about the NHS. The NHS isn't everything, but sometimes that's taken into two-phase testing. The NHS has a huge budget, huge power with reach into our lives, huge workforce, and therefore should be a critical part of our solutions. As part of the health creation approach, how do we supercharge prevention in the NHS? We think that's about bringing more services into the communities, both to the home and building the neighbourhood NHS, something that I've talked about since our previous work with our SBT update from the last review. Taken together, that's a plan that I think attempts to be three things. One, it attempts to answer the specific health challenges that we face today. What are the specific answers that we can bring forward to actually get to grips with the 21st century and deliver better health? So it's about the economy. It's about delivering the inputs into growth that will allow the UK to thrive. But thirdly, this is also a plan for thinking about sustainability of the NHS. The NHS is, in terms of providing the sickness care people need, dependent on the success of these other recommendations. Indeed, we show that an NHS that works for public health and public finances relies on much of the other recommendations we make. It's cross-site plan for prevention, and you know, a vision specifically for our mission in the next parliament. So what we hope that means for people in the room is that it provides store of data or a touch point for ideas, a framework for thinking, a point for collaboration. And obviously, in many ways, when you release a mission like this, the hard work really just begins as we now move towards thinking through how to change, how to think about the future of government policy. It will take a long time by taking the project to fully restore the nation's health, but there are ideas out there, so they can help us do that. So I just wanted to give that extra bit of detail. What I also want to do now is hand over, think about handing over to our last speaker, because we've heard a lot about the challenges, we've heard lots of kind of expert reflections, but at this event we were also really keen to hear about some practical things that are happening, some green shoots of what we might call the health-led economy. So I'm delighted that we'll be welcoming on stage Sarah Douglas, who runs the Liminal Space. Liminal Space is a mission-led creative consultancy focusing in great part on new ways for people and organisations to engage with health. We've highlighted much of the work of the Liminal Space in thinking about new ways of doing health in workplaces and other settings and communities. And what I think is really exciting is that they're thinking through how we bring health outside of the purely rules of hospitals and lots of other domains of our life. They're doing so with a focus on good design principles and working with people in a way we just heard from the Secretary of State as being very important, and working with people to work out what works for them and how to say that for you. So I can see Sarah to my left. Fantastic. So delighted to welcome Sarah on stage and thank you all for coming today.
I must say it's great to be representing green shoots, so thank you for that. So I'm here to tell you about an initiative called Nightclub, which is an intervention that we've created that's all about improving health at work, and I think embodies much of the thinking that we've been doing about today in practice. So Nightclub shows up at workplaces in the middle of the night. Employees come to level sleep, to have a snack, to connect with colleagues. But what's that got to do with health? Well, even though it doesn't look like health or sound like healthcare, Nightclub is a model of what health could look like in work, in community, and integrated into our daily lives. By supporting people not according to a specific health condition, but based on their challenges and needs at the time. Supporting people like Joe. So I first got to know Joe on the night shift at the supermarket logistics depot where we've been running the Nightclub programme. He told me how he has 5 energy drinks a night just to stay awake on his shift. That crisps are his go-to meal. And after working his night shift and his hour-long commute home, he then snatches 2 or 3 hours sleep in between school pickups and then gets ready to go on his second job. He was chronically exhausted all the time, suffering from migraines and panic attacks. So many stresses all together affecting every part of Joe's life. Long-term conditions, his ability to do his job, and his personal relationships. I'm afraid Joe is not alone. 8.7 million people in the UK work nights. That's over a quarter of our workforce. This is a hidden army of people who keep our 24/7 society running. Over a quarter of our workforce. Most people can't imagine it's that. But lack of sleep in the workforce costs the UK economy 50 billion per annum in terms of lost productivity, health and care costs. And we know that night shift work contributes to a number of really serious health conditions, from depression and diabetes to a host of mental health disorders. And it's a social issue too, because night workers are 6 times more likely to get divorced, are often in very low paid jobs, where they're facing the sharp end of the cost of living crisis, literally working around the clock to make ends meet. This is another perfect storm. But there's no getting away from shift work, because we need our 24/7 economy. So how do we shift the dial on a challenge like this? Night Club was our response. It's a preventative health intervention that provides holistic support to people like Joe on shift at night. And I was really delighted when Wes Streeting started out by saying, well, I'm not here for Night Club, because actually that's exactly what this intervention is about. Because we know that telling people what to do around their health behaviours sometimes doesn't work. So really, what we are trying to advocate for is kind of health by stealth. You know, it's bringing people into a conversation in an entirely new way. So our shipping container travels the country and is staffed by sleep experts who deliver really practical support on how to improve sleep and health. We also create a space where night workers and their employers come together to identify how to improve life on nights. And we work with business leaders to make the long-term changes to things like nutrition, shift patterns that we know will result in better health. So far, over 10,000 employees have visited Night Club, from Portsmouth to Inverness, across over 30 major employers, including TfL, Britvic, Veolia, and the Co-op. You can see many of them represented here. Together, our employer partners have over 1 million staff. And what they see is that when employee health benefits, so too does business. They've seen absence rates go down, and they've seen engagement increase. So today, Night Club is largely employer funded. Night Club and many other programs we've created are actively delivering health as part of everyday life, working outside of clinical settings, connecting with people where they are and on issues that they care about. So we think a lot about what an empowered, healthy community would look like. And we know that citizens are going to need a different invitation to engage in this preventative model, with different incentives and a different social contract. So my question is, coming from a practice lens, how can we centre people in the creation of a health economy? And I want to share with you some key design principles that we use across our work and from our role as designers of interventions like this, slightly outside of the traditional health system. 1, we need to reframe where health happens. 2, we need to give people a reason to engage and participate. And 3, we need to amplify lived experience and show people how their views and voices help to shift systems. I'm going to expand on my first principle. We need to reframe where health happens by thinking creatively about alternative settings. With Night Club, this is about coming to your workplace while you're on shift. That might sound really obvious, but actually it was transformational, because people like Joe miss health checks, they miss training, and they miss support because all of these activities take place during the day. So a simple shift that wasn't terribly costly to provide health support at night has made a big difference. In one of our other programs, a travelling food truck goes to people around the country to help them rethink their food choices in a non-judgmental way, at the moment when what's for dinner is front of people's minds. And in another, we meet families in shopping centres in the places that they use to help them explore and discuss end-of-life care, another topic that we know is hugely important to the public. But we do this through the vehicle of a pop-up travel agency, helping to think through what that last journey might be like. We champion health delivery within communities and their spaces, whether at work, rest, or play. And as we know, the dynamics of healthcare are set to get a lot more social as we move away from the concept of appointment-led care. So as well as bringing health into everyday life, we need to be thinking about how we bring citizens into health in new ways. That leads me to principle 2. We need to give people a reason to engage. So rather than placing undue demands on people, we should be thinking creatively about what we can bring that's enticing and enriching them. Whether that's a new experience, entertainment, something to do as a community or a family. Whether it's learning new skills. Whether it's learning new skills or simply access to respite when people live close. This is even more crucial as we shift to a preventative care model, because without the worry of symptoms or known personal risk factors, the sorts of things that get you calling your GP will need an alternative impetus to engage. This is where language and stories matter immensely, because people need to feel they need to feel motivated to participate. That's why we co-designed the presentation of our work with affected communities to make sure that it resonates, doesn't fail at first. For example, nightclub is very high vis, as you might notice. There's no calming lavender sleep tones in this programme of work. That's because we developed it with night workers so that it feels like their world and it's vibrant and engaging, which is what they wanted, often contrary to our expectations. Finally, principle 3. We need to amplify lived experiences in order to change systems. That sounds like a lofty ambition, doesn't it? But I think that, really centering where people are coming from and the experiences that they bring to the table is critical to unlocking the parts of this process. So let's forge meaningful connections between business, research, state, and citizens. Nightclub doesn't simply put the onus on individuals to make change. That's impossible for Joe to do anything with the life situation he has. It also helps employers understand how to make the workplace thrive and to recognise their duty of care. And it speaks the challenges faced by both employees and businesses back to policymakers. For example, in our policy and influencing work, we advocate for annual health checks for night workers, something which, shockingly, isn't either routine or required. We brought night workers to Parliament and shared insights from thousands of them to the Business Select Committee. In a number of our programmes, Job Design Lab, we're bringing together players across the system to design an approach to tackling the health impacts of precarious work. Gig economy workers, community organisers, HR leads, council staff, all working closely to build a more hopeful future of work and health. So those are 3 principles from our practice that I wanted to share with you today. I know that many of us are working in this space, including many people in this room today. And we know that it can be transformative to achieving the vision that we're talking about here today. One that helps us move from the sickness model of health policy to a health creation. If you're interested in any of the topics I've shared or to find out more, then do grab me over lunch. I think I'm the last person that's keeping between this room and lunch. Or you can find out more about it. Thank you.
So, really inspiring, and it's great to see some of these big wealthy ambitions that require structured attention whiteboard, but into practice and reality, just hope that we can in fact do it. I'm not going to say anything more. You've heard lots from our team from us today. I just want to thank everyone here for coming and for joining us. I want to thank the team again and our commissioners. And I also want to thank those who financially supported the work and enabled us to do this really important project. They are AstraZeneca, Gilead, Pfizer, Impact on Urban Health,
BMS, AbbVie, the British Heart Foundation, and the Alzheimer's Society. And without those supporters, we wouldn't be able to do this work, and we wouldn't be able to have the impact we have. So thank you for them. I'm now inviting you to join us for lunch, healthy lunch, as you might expect, and please do keep in touch with IPPR as we take this work forward. Thank you very much.